Today I'll be presenting neuroblastoma. The term neuroblastoma is commonly used to refer to a spectrum of neuroblastic tumours, which also includes ganglioneuroblastoma and ganglioneuromas. However, neuroblastomas account for 97% of all neuroblastic tumours. A neuroblastoma arises from early neural crest precursors that undergo transformations secondary to genetic or epigenetic events that lead to blocked or aberrant developmental differentiation. Neuroblastoma is almost exclusively a disease of children. It is the third most common childhood cancer after leukemia and brain tumours, and is the most common solid extracranial tumour in children. Incidence rates are age dependent. The median age at diagnosis is 17.3 months, and 40% of patients are diagnosed before 1 year of age. Neuroblastomas are the most common cancer among infants younger than 12 months, in whom the incidence rate is almost twice that of leukemia. Little is known about the etiology of sympathetic nervous system tumours. The early age of onset suggests that preconceptual or gestational environmental events may play a role, such as exposure to drugs, hormones, toxins, or viruses. Therefore, maternal and fetal factors that may be associated with the subsequent development of neuroblastoma include the following: opiate consumption, folate deficiency, toxic exposures, congenital abnormalities, size for gestational age being too big or too small, and gestational diabetes mellitus. Neuroblastomas can arise anywhere throughout the sympathetic nervous system. The adrenal gland is the most common site, followed by the abdomen, thoracic, cervical, and pelvic sympathetic ganglia. Less commonly, tumours arise within the central or autonomic nervous systems. In approximately 1% of cases, a primary tumour cannot be identified. Neuroblastoma metastasizes to lymph nodes, bone marrow, cortical bone, dura, orbits, liver, and skin, and less frequently to pulmonary and intracranial sites. The presenting symptoms are dependent on the location of the tumour. Approximately 2/3 of primary neuroblastomas arise in the abdomen. Therefore, these patients will often present with pain or fullness, abdominal mass, or rarely intestinal obstruction. The child may have symptoms associated with compression of the bladder or bowel. Large abdominal tumours can also compress the venous or lymphatic drainage, leading to scrotal or lower extremity edema. Furthermore, neuroblastomas may arise in the thoracic and paravertebral region or metastasize via the lymphatic and hematogenous routes. Therefore, common signs and symptoms are listed below. However, patients with localized disease may actually be asymptomatic. The differential diagnosis of neuroblastoma includes a variety of neoplastic and non-neoplastic conditions and varies according to tumor location. Distinguishing these conditions from neuroblastoma may be particularly difficult in patients whose tumours do not produce catecholamines or who do not have an obvious primary tumour. When their tumour arises in a suprarenal location, Wilms tumour and hepatoblastoma should be considered. In thoracic and retroperitoneal locations, lymphoma, germ cell tumours, and infection should be considered. Metastatic involvement of the bone marrow should be distinguished from lymphoma, small cell osteosarcoma, mesenchymal chondrosarcoma, Ewing's sarcoma, family of tumours, primitive neuroectodermal tumours, undifferentiated soft tissue sarcomas, such as rhabdomyosarcoma and leukemia, and if the spinal cord is involved, either as a metastatic lesion or by extension of the primary tumour, the differential diagnosis should extend to other neurodevelopmental tumours such as desmoid tumours, epidermoid tumours, and teratomas, as well as astrocytomas. All patients with suspected neuroblastoma should undergo a complete history and physical examination. Most patients will undergo laboratory evaluations including routine bloods, serum chemistries and tests of liver and kidney function, evaluation of urine or serum catecholamine metabolite levels, VMA, HVA, should be obtained as well to assist in diagnosis and monitoring of disease response, since levels are elevated in greater than 90% of patients with neuroblastoma. Histologic confirmation is required for definitive diagnosis. Tissue is usually obtained by incisional biopsy of the primary tumour or bone marrow biopsy in patients who are suspected to have metastatic disease in the marrow. The diagnostic procedure should be discussed in consultation with a paediatric surgeon and oncologist. A complete evaluation of patients with suspected neuroblastoma is mandatory before beginning treatment. The evaluation is best completed at a major paediatric centre where paediatric oncologists and radiologists are familiar with neuroblastoma and can be closely involved in the planning and coordination. The goal is to evaluate the extent of the disease, which in turn determines the clinical and pathologic stage, treatment, and to a greater extent, prognosis. Neuroblastomas are now staged using the International Neuroblastoma Risk Group Staging System as depicted. Staging requires complete and standardized imaging, including CT or MRI and MIBG scanning. This slide is another depiction of the International Neuroblastoma Staging System. Due to outcomes being significantly better for patients with localized disease and younger age, several groups have attempted to develop screening programs for neuroblastoma in infancy by measuring urinary catecholamines. The aims of these studies has been to ascertain whether early detection would decrease the incidence of high risk or advanced stage disease and ultimately improve survival. 4 large studies from Japan, Canada, Austria, and Europe have screened over 10 million children at either 6 to 7 months or 1 year of age. All of these studies were remarkably similar. Screening led to more neuroblastomas being diagnosed in the screened population. However, the additional tumours were mainly low-stage tumours and had favourable biological features. Many of these tumours presumably would have undergone spontaneous regression and never would have been diagnosed clinically. There was no decrease in the incidence of high-risk tumours in children beyond the age of screening. Mortality was not lower in the screened populations. Therefore, it was concluded that screening for neuroblastoma with urine catecholamines does not reduce mortality and is therefore not recommended. The treatment of neuroblastoma is based on the classification of patients into low, intermediate, and high-risk categories based on these 5 characteristics at the time of diagnosis. Surgery is indicated in most patients with low-risk tumours. Small neoplastic tumours presenting in the first year of life are typically managed with observation alone, as tumour regression with low-risk disease is likely. 2 to 5 year event-free survival rates with surgery alone are greater than 93% for children with stage 1 disease. Because recurrences can be successfully managed with further surgery or chemo, a 5-year overall survival rate is 95% in stage 1 disease. For children in intermediate risk neuroblastoma, a moderately intensive multi-agent neoadjuvant chemotherapy such as doxorubicin, cyclophosphamide, and etoposide is recommended with or without surgical resection. The goal of treatment is to deliver a sufficient duration of chemotherapy to achieve at least a partial response and resolution of metastatic disease. The duration of chemo is typically 6 to 24 weeks and may include the following regimen: 5 courses of chemo followed by surgery, another course of chemo, radiation therapy for gross residual disease, and 4 more courses of chemotherapy. The 4-year EFS for patients with favourable biology was 100%, while for infants with at least one unfavourable biological feature, the EFS was 90%. In high-risk neuroblastoma, treatment includes the following components: induction chemo, local control, being surgical resection and radiotherapy, consolidation with tandem hematopoietic stem cell transplantation, and maintenance therapy. Immunotherapy can also be used in relapsed or refractory disease. Neuroblastoma, or its treatments, may affect survivors through the following mechanisms: secondary malignancy, cognitive deficits, cardiac toxicity, sensory neural hearing loss, chronic kidney disease, endocrinopathies, and scoliosis. Thank you for listening to my lecture.